Oh, good morning. I'm very much hoping that this is working. I'm a bit of a technology Luddite. So on the optimistic point of view that this is working and you're able to see this, I'm going to get started. There's a limited amount of time that I've got this morning, so I'll get through what information that I can do. What I have spent a little bit of time doing is what I have spent some time doing over the week is collating some of the questions and issues that were emailed to me. I'll try and cover as many of those things as possible in this lecture today. And then what I've also prepared is an Excel spreadsheet. And on that Excel spreadsheet, I have put all of the kind of cramming things that I think might help for you just before your exam. And I've also made a Word document with answering all of the questions that I was asked since the lecture last Sunday. So this is a bit new for me. I don't do this very often. It is strangely distracting having little images, but I have to monitor that. Last time I tried to do this, I got about 20 minutes into doing a live stream. The live stream cut off, and then I spoke to myself for about an hour and a half. Teaching myself stuff without anybody watching and without it being connected. So on the unlikely event, I think I've organized some of the technology a little bit better, but on the unlikely event that I do get cut off, then I won't try restarting the stream again. I'll just accept that I'm not technologically minded, and I will send out via email the documents that I've produced for you. So what we're going to do is quickly start off with I've got some notes down here for me. Wanted to cover a little bit about hyperthyroidism. The main bits that I really wanted to cover from hyperthyroidism is the thyroid uptake scans, treatment of hyperthyroidism, association of diseases and things like that. So I will get started as Graves' disease. So, there are some features that are specific to Graves' disease and Graves' disease only. And the important fact is not to get that mixed up with all of the causes of all of the causes of hyperthyroidism give you these features. So the features specific to Graves' disease and Graves' disease only thyroid acropatchy. This is when you look at nails and they look as though they're clubbed. But when you hold your nails together and have a look through, you can still see the little diamond shape. But it is thickening of the base of the nail, and that's thyroid acropatchy. You only get that in Graves' disease. Pretibial myxedema. I hate this term because it isn't really edema. This is thickening of the skin on your lower leg. It looks dimpled, a little bit like orange skin. I don't like it because they've used the term edema in it. Now I have to use pitting edema whenever I'm describing what edema is. All edema is pitting, which is why we shouldn't have called this pretibial myxedema. So we've got some finger features first, which is thyroid acropatchy. Then we've got a lower limb dimpling of the skin, which is pretibial myxedema. And the next is exophthalmos. Exophthalmos is eyeball sticking out due to Graves' disease. So if you just want to say that somebody's eyeball is sticking out, sticking forward, then you say that that is proptosis. Proptosis is eyeball sticking out. If eyeballs stick out and you think that the cause is Graves' disease, only then do you use exophthalmos. This is eyeball sticking out. You look at this by turning the person's head side on and seeing whether the fronts of their eyes protrude further than you're expecting it to do. And that's the kind of clinical examination that you do. Those are specific to Graves' disease. And the point that I would also like you to take away is Graves' disease can give you either hyperthyroidism, which is the most common, euthyroidism, and we use the term euthyroid to say normal on clinical examination, the person isn't thyrotoxic, which is showing signs of hypothyroidism. And then you can also be hypothyroid with Graves' disease. That is due because this is a type 5 hypersensitivity reaction. You are making antibodies at the aimed towards the TSH receptor. So TSH comes down, stimulates the TSH receptor, and that makes your body produce thyroxine. If you make antibodies towards that TSH receptor, the reason that it's called a type 5 hypersensitivity reaction is because those antibodies, as they are attacking the receptor, they're also stimulating that receptor. So the antibody attacks the receptor, stimulates that receptor, so you get some thyroxine production whilst it's being attacked. And the point of that attack is that it is damaging it, and I think about it a little bit like hitting a doorbell with a hammer. When you start, bang, 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 and each time you hit it, it's ding dong, ding dong, ding dong, ding dong, ding dong. Then after a little while, after hitting it, the doorbell starts to break, so you end up with ding dong, ding dong, ding dong, and eventually you could have beaten it so badly that it fails to function anymore. And that's the point where when you're hitting it and it's being stimulated every time, you are hyperthyroid. When it's only being stimulated, bing bong, every few hits, that's euthyroid. And when you've damaged that receptor so badly that it's no longer functioning, you can then be hypothyroid. But bear in mind that even though you can be hypothyroid with Graves' disease, you can still have thyroid acropathy, pretibial myxedema, and exophthalmos, even though you are hypothyroid with Graves' disease. So the part to take away is these features here are specific to Graves' disease. You can be hyper, or hypothyroid with Graves' disease. That the cause of it is a TSH receptor antibody. So we have to put anti at the beginning of it, anti-TSH receptor antibody. And the last part that sometimes comes up is this is a type 5 hypersensitivity reaction. So that's really what we're taking away from Graves' disease right now. Then we're going to move on to features that we see with anybody who has hyperthyroidism. So when we say hyperthyroidism, that's something that we see on blood tests. If we can see physical features of hyperthyroidism, then we call that thyrotoxicosis. Again, we've talked through euthyroid and hypothyroid. So we're going to talk about thyrotoxicosis. These are features. So I'm just going to check that all of the IT is working appropriately. Okay, a lot of background noise. I'm going to try turning down the microphone a little bit. That may solve the problem. Okay, if that's gone too quiet, then somebody can let me know. I'll just check the messages every now and again. Okay. So features of thyrotoxicosis are the same types of features that you would see if you have, okay, thank you. These are features that you would have if you had too much adrenaline. So you can think about features of thyrotoxicosis in the same way as you would of what would happen if you got very, very angry. As you get angry, as I start to have a conversation with another consultant and we're disagreeing, my eyelids start to come further retracted and you can start to see the whites of my eyes because I'm angry and I'm irritated. And those whites I can see because the sympathetic stimulation is starting to bring back my eyelids. And as I bring back my eyelids and the eyelids come back, you can see all of my eye. So you can see all of my iris. Just because I pull my eyelids back, that doesn't mean that my eyeballs are sticking out any further. So lid retraction of pulling my eyelids back is not the same as having exophthalmos. So distinguish lid retraction versus exophthalmos. And if you are hyperthyroid with Graves' disease, then you can have lid retraction and exophthalmos. If you have thyrotoxicosis from any other condition, you'll only get lid retraction. Your eyelid is innervated by two different muscles, one of which you have under voluntary control. That's levator palpebris superioris. That's one where I can pull my eyelids back voluntarily. And then I have a second muscle, which is called Muller's muscle. And Muller's muscle is sympathetically innervated. This is important for two reasons. If I get significant extra sympathetic stimulation, my eyelid comes back, and you can see it because now either I'm angry, lots of adrenaline going through, I'm thyrotoxic. On the other end, if I then get damage of sympathetic supply to Muller's muscle, now my eyelid starts to drop down and looks floppy and I get a ptosis. This is what happens in Horner's syndrome when you get damage of the sympathetic tract. The same is true for ptosis, where you have a third nerve palsy and you get damage of that sympathetic tract. And sympathetic damage causes dropping of that lid. Sympathetic overstimulation causes retraction of that lid. And we're going to come back to Horner's a little bit later because a few people wanted to do a little bit of neurology and some stroke bits and some brainstem pathology, so I put something in for that. So lid retraction with thyrotoxicosis, you can have increased heart rate, and with enough stimulation that can put you into atrial fibrillation. You can be heat intolerant. Don't know whether you, as the nerves kick in before you go in for an exam or you've got to do a presentation, you can start to feel sweating and it gets a little bit wet underneath your arms and you're all hot and flushed, and that's coming from sympathetic stimulation. You may be sympathetically stimulated with thyrotoxicosis for so long that you want to take your clothes off, wear summery type clothes in winter, but there is a difference between being heat intolerant and then ending up with a pyrexia. If you end up with a pyrexia, you're now moving from thyrotoxicosis to a thyroid storm. If I start to move from having a high heart rate or atrial fibrillation to signs of CCF, then that is part of a thyroid storm. Same with what's going on neurologically. You can feel quite nervous and a little bit kind of agitated, unsettled. That's coming from neurological stimulation, overstimulation. If it now gets to a stage where your neurons are being so sympathetically stimulated and you end up having a seizure, these are all features of a thyroid storm. So this is just to distinguish between, there are specific features for Graves' disease, there are features of thyrotoxicosis, but as soon as you move into one of these, this is a thyroid storm and you need to be admitted to hospital. So what are we going to treat people with hyperthyroidism? The medications that we're going to use to treat it are beta blockers. So beta blockers I can subdivide into two groups. Those that are going to help because my heart rate is increased, or I may be an AF. Those can be more cardio-selective beta blockers. But also propranolol. And we talk about propranolol specifically because it is the only beta blocker that can cross the blood-brain barrier. As it can cross the blood-brain barrier, then it can deal with the neurological symptoms of hyperthyroidism and thyrotoxicosis. And those are going to be that agitated unsettledness. So this can help with the symptoms. We can also up-regulate GABA and use benzodiazepines. And benzodiazepines help settle. They work all around the body, so they can have somewhat of an effect on heart rate and agitation, and also lowers the likelihood of you having a seizure by increasing your seizure threshold. Popping back quickly to beta blockers, we have a decrease in T4 conversion into T3. So beta blockers also do this as well. Now, why is this helpful? It's helpful because T3 is the most active and has the shortest half-life of your thyroxine molecules. So T4 does have a thyroxine effect, but T3 is much more active, much more potent, but much more short-acting. So beta blockers decrease that. Just check my technology, see whether this is working. Yep, still seems to be working. So we've got beta blockers, benzodiazepines. We can use medications directly that decrease your body's production. So this is decreased production of thyroxine. And these two drugs are carbimazole and propylthiouracil. The one with P in is the one that you use with pregnancy. Carbimazole, now in reality, when we were at the course last week, we talked about how people who were taking certain asthma medications, there were some references in the BNF to the fact that it may cause Churg-Strauss, but we said that that was a back-to-front association, that people with difficult to control asthma weren't turned into Churg-Strauss by asthma medication, but people with Churg-Strauss were likely to have difficult to control asthma, therefore they would likely to be on adjuvant therapies for asthma. In the same type of way, carbimazole, there were reports that when pregnant women took carbimazole and they gave birth, their babies had this condition called aplasia cutis. And aplasia cutis is a baby being born with a lack of skin covering the top of their head. And that lack of skin left this horrible open-looking wound. It was very, very distressing for mothers. It did heal, but because of the reports of this, carbimazole was thought to trigger it, and it wasn't. In actual fact, what we found out was propylthiouracil decreased the incidence of aplasia cutis. Carbimazole didn't change it, but still we're left in a situation where we prescribe propylthiouracil. If you're doing endocrinology, you'll still see endocrinologists using carbimazole in pregnancy and later pregnancy. But for exams, P is propylthiouracil for pregnancy. So both of these decrease the amount of thyroxine you produce. And there's two ways that you can give these, which is either you throw all of the medications in the world at the patient, you give them all of this, their thyroid gland then goes to sleep. Once their thyroid gland goes to sleep, then you give them thyroxine to replace the thyroid hormone that you've blocked by giving too much of this medication. And that's called block and replace. The better way to do it is by doing titration, and you increase the dose of these slowly until you get to the point where the patient is euthyroid. You carry that on for a period of time, and eventually sometimes you're able to stop these medications, and that's called titrate. Again, in pregnancy, you should always use a titration of these medications and never block and replace. It's obviously much cheaper to do a block and replace regimen. You bring somebody in for one clinic appointment, you prescribe them all of the carbimazole and propylthiouracil, then you prescribe them thyroxine, and it can all be done and dusted. So you need more clinic appointments, but it's much better tolerated titration of medications. Then moving on to the next medication you can use is actually iodine. That kind of goes a little bit counterintuitively. Why would you give somebody iodine when iodine is used to turn into thyroxine? So wouldn't giving somebody iodine make them more hyperthyroid? I don't know whether you watched the series about Chernobyl, where some of the scientists started to notice their Geiger counters going up, and so they started passing out Lugol's iodine tablets. So they would take these iodine tablets because they knew that radiation was coming and there was going to be fallout. So why did they do that? Well, your body's got this very clever mechanism, and that mechanism is that if you come into too much iodine and you flood your body with iodine, your body says, do you know what? It's probably a better idea right now that we turn our thyroid off, let our thyroid go into hibernation while we go through this huge peak of iodine. And when it drops back down to normal, then we'll go about business as usual. So iodine, large doses of iodine, can shock the thyroid and make the thyroid gland go to sleep. This going to sleep then means if you are in a thyroid storm, if I give you iodine, then that can turn off your iodine. It can turn off your thyroid gland to shock your thyroid gland, so that then the amount of thyroxine then drops down and it takes you out of the thyroid storm. Always make sure that you give one of these medications over there, carbimazole or propylthiouracil, before you give iodine, because every now and again you do get a slightly mischievous thyroid gland. And when you give iodine and you're already in a thyroid storm, the last thing you want to do is cause any increase in thyroxine. So give this first and then give iodine afterwards. It's not important for your exam, but these are usually in dyes or contrast media, and so you need to go down to radiology, and radiology keep these in contrast. Another treatment that's not really used so much anymore is radioactive iodine. And radioactive iodine, you take the radioactive iodine, the iodine is taken up by the thyroid gland, the radioactive particles that come off that radioactive iodine then irradiate the thyroid tissue that's around the iodine and then kills that thyroid gland. Most of the time that you see this is in metastatic thyroid cancers, where thyroid tissue has metastasized out elsewhere. It still will take up some iodine. So you give them radioactive iodine. That radioactive iodine is taken up by the thyroid cancer and then is kind of given internal radiotherapy and ends up killing the thyroid tissue around it. Again, you never want to do this in pregnancy. Never in pregnancy. Again, because not only will it ablate the thyroid gland of the mother, but it also ablate the thyroid gland of the developing fetus. And then the child will be hypothyroid permanently, as well as the complications of giving a very early developing fetus something that's radioactive. We'll put that to one side. Going to move on to thyroid uptake scans. So we use thyroid uptake scans. They come up in exams more than you use them clinically, so we should really know them. We talked again on the weekend that if you had a tumour growing in a gland and that tissue, that tumour, was secreting the same hormone than should natively be coming from the gland, that was likely to be a benign adenoma. When we move on to saying that if there's a tumour growing within an endocrine tissue, either that will be a non-productive, it won't be producing any endocrine function, won't be producing any hormone, or it will be producing a hormone that it shouldn't be coming from that specific gland. So I think the point that I'm trying to communicate is when you look at a thyroid gland, this is going to be my thyroid tissue. That's a very badly drawn thyroid. If a tumor is growing within it, there won't be any thyroid uptake. So it would actually be a cold spot. So when we look at the thyroid gland and we see the amount of uptake that's in it, the thyroid is uptaking normally, but that cold spot, let's do that, that cold spot, those are the ones that we're worried about whether it is a cancer. So cold spots, cancer. Now there could be something else. I mean, there could be a little cyst in your thyroid, or there could be something benign. But the part that I would like you to take away is cancers, cold spot. Thyroid uptake scans look at how metabolically active the thyroid gland is. So let's have a look at Graves' disease. And we said Graves' disease would either be hyperthyroid, euthyroid, or hypothyroid. So the types of things that we get in a thyroid uptake scan is either a very hot thyroid. So I'm going to color this in a little bit harder. So this in exams is the most common presentation, is increased uptake, global uptake. This is in your exam going to be Graves' disease. That's how Graves' disease looks. Now just bear in mind that even though in your exam it's always going to be increased global uptake equals Graves' disease can give you increased global uptake with hypothyroidism, a euthyroid, kind of a normal looking thyroid gland, and then a cold gland if you end up with hypothyroid. But for exam world, increased global uptake equals Graves' disease. We could have hot spots on your thyroid gland, and hot spots on the thyroid gland, remember cold spots cancer, hot spots, this equals toxic multinodular goiter. Most frequently in the exam they'll try and trick you to picking that this is cancer because there's a single hotspot, and they'll try and lure you down to it's cancer, but it's actually a toxic multinodular goiter. Because these are overproducing thyroxine, the rest of the gland is quite cold because TSH is turned off. And because TSH is turned off, the normal thyroid tissue itself is not being stimulated to produce thyroxine. So that's a toxic multinodular goiter. There's another interesting thyroid uptake scan, which is a cold thyroid gland. Oops, I've had a bit of a technical issue. My pen stopped working. Okay. Okay, hold on a second. Joys of technology. I've got to plug a little USB in to get it working. Okay, there we go. A bit of a panic there. A globally cold thyroid uptake scan, and that cold thyroid uptake scan is with hyperthyroidism. You can't have a cold gland with hyperthyroidism with Graves' disease. This is a slightly different pathology. When your thyroid gland is functioning normally, your tissue produces thyroxine. Then some of that thyroxine is put away It's kind of hidden underneath your pillow for a rainy day. So you put some away in a savings account, and then you carry on spending the thyroxine that you're making in the thyroid gland. If you pick up a viral illness, that viral illness can start causing irritation to the thyroid gland. So it's under attack now by a viral infection causing inflammation. The thyroid gland goes into a panic and says, stop producing thyroxine. You stop producing thyroxine, and at that stage, the viral infection is still causing inflammation to the thyroid gland. That inflammation causes your thyroid gland to release its stored thyroxine. So although this gland is not making, any thyroxine, it is releasing the stored. So I think about this a little bit like being bullied at school. You've got this small kid in the playground, and then the bully is the viral infection and inflammation, and the bully picks up the nerdy school kid and starts shaking him by his ankles. And whilst he's shaking him by his ankles, all of his lunch money is falling out of his pockets. And as they're falling out of the pockets, the bully's friends are all picking up the money on the ground. And this is the same thing. The thyroid gland is under attack. Whilst it's under attack, it's releasing all of its thyroxine, all of its lunch money in its pocket. And there are 3 stages that patients with, this is called subacute thyroiditis or de Quervain's thyroiditis or post-viral thyroiditis, that's all the same condition. De Quervain's or post-viral or subacute. Those are all the same condition. De Quervain, don't confuse de Quervain's thyroiditis with de Quervain's joint. De Quervain's joint is the slightly fibrous joint that's down from your knuckle. You kind of get arthritis in it, and it gets quite painful when you're older. You can do steroid injections into it. So in de Quervain's thyroiditis, as you are early on in the process, the little nerdy boy's still got lots of money in his pockets, and money's falling out of the pockets, and you are hyperthyroid. As he carries on shaking and the odd coin is falling out of his pocket, then you're euthyroid. When all of the coins are fallen out of the pocket and there's no money left, the patient then becomes hypothyroid. The treatment for this is that you do nothing. You let the bully shake him by his ankles, and hopefully what will happen is the lunch money will fall out the pockets, they'll collect the money, and then they'll leave this poor little nerdy thyroid alone. In reality, if the bullies carry on and they're still shaking them, and there's no more money, and the person has become hypothyroid, at that point you step in and say, enough's enough. You've got to leave that person alone. And at that case, then you give steroids just to decrease inflammation. So we've done thyroid uptake scans. I think just a quick little bit on thyroid cancers. So thyroid cancers, there's something to be said for most of the thyroid cancers, and you only really need to have one piece of information for each. Quick check, see whether this is working. Yep, still working. Quick for each. So we start at the top, which is papillary. Papillary thyroid cancer is the most common. That's about all you need to know. Then there's follicular. That's what the F is there for. I'm not even going to write that down because it doesn't come up in exams very often, because there's not too much to say about it. And if they're going to examine you on thyroid cancers, they're going to want to ask you something about one of the others. Then medullary. This comes up because it's associated with multiple endocrine neoplasia, type 2. The other importance with this is medullary thyroid cancers If you remember again back to last weekend, we talked about calcitonin, and I said at the time, calcitonin isn't particularly important in calcium metabolism. And the things that were important was parathyroid, which made your calcium go up and your phosphate level go down. We talked about vitamin D, making your calcium go up and your phosphate go up. And then calcitonin itself was mainly used, especially for exam purpose, to monitor for medullary thyroid cancers. So this is a tumor marker. That's the way we use it. So calcitonin, useful for monitoring the development of a medullary thyroid cancer and multiple endocrine neoplasia type 2. Interestingly, it's pretty good as a drug as well. If you have a look at the data, giving intranasal calcitonin settles pain and gets people to mobilize faster than opiates if they have an osteoporotic fracture of the spine or of the pubic rami. Not really used so much anymore, got quite expensive at one point, but it's as a side point. Next, so we've got papillary is the most common. Medullary is associated with men and is monitored with calcitonin. Anaplastic, you need to know the clinical presentation of this. This is a thyroid nodule that grows very, very rapidly, compresses the airway quickly, happens usually in elderly people, rapidly fatal, invariably fatal, and there's not really a treatment that works for it. So rapid. So this will be more often than not part 2 question with a patient presenting with this rapidly progressing, and then you've got to pick which cancer it is, and they'll give you the list of them as the best of 5, and you've got to pick anaplastic. And then lymphoma. This is very, very rare. But what's important for this is, because this is not tissue that is lymph node or spleen, going again back to last weekend, we talked about the Ann Arbor staging, and the important part of this was if you get lymphoma tissue in your thyroid, that jumps you to stage 4 because it's extranodal spread. But the part that's an exam is which one of these is at least likely to be, and lymphoma, a tumor of the thyroid, is least likely to be a lymphoma, and it's the rarest. Covered everything that I want to. Oh yeah. Whilst we're talking about multiple endocrine neoplasia, we talked a little bit about pheochromocytoma. And the reason that we talked about that, referencing back to last weekend, was we wanted to do a test to confirm whether somebody had Cushing's disease. And the test that we said we could do was a 24-hour urinary collection of cortisol was one test. We could do an overnight dexamethasone suppression test with 1 milligram of dexamethasone, so a really small dose. And you can also do kind of nocturnal salivary samples, but in your exam, it's going to be one of those two. I said I like doing the 24-hour urinary collection because then I can do a 24-hour urinary collection of metanephrines at the same time, because then I can screen for secondary causes of hypertension. So there is this kind of sideways movement between an understanding of what tests that you're doing for what endocrine and what you can use them to double up for. So quickly, for a quick overview of multiple endocrine neoplasia, I know you can look at this in a book, but I want to point out the things that come up in exams where they try and trick you. So we'll quickly go with 1. So 1, and then there's MEN2. MEN2 is split into MEN2A and 2B. MEN2 share 2 things in common, and then there's something that's specific to MEN2A, and then MEN2B share the same 2 things in common down here. Is not examined as much as the comparison between MEN1 and MEN2A, and then there's something specific up here. So we'll start with MEN1, and the bit that comes up in questions most is parathyroid. Now, you do get parathyroid in MEN2A. So they often try and trick you with questions. It's probably every other exam from what's been reported. Is in men 1, you get a parathyroid adenoma. That is a benign adenoma of the parathyroid gland, usually on one side, that secretes parathyroid hormone or parathormone. That can give you a high calcium and a low phosphate. And sometimes, thinking back to last weekend, an inappropriately normal parathormone level. The difference between men 1, this parathyroid here, and parathyroid over here, is this causes hyperplasia. So the parathyroid tissue hypertrophies and then overproduces too much parathyroid hormone. So they try and trick you out by saying which one of these two things gives you a parathyroid adenoma, or there'll be something about parathyroid hyperplasia. So that's the most, I would say, most frequent trick is this in an exam. We've already talked on the last slide about medullary thyroid cancers over here, and those giving you calcitonin. Coming back to here, we do have medullary thyroid cancers secreting calcitonin and pheochromocytomas. So these occur in both forms of multiple endocrine neoplasia type 2. I'm going to leave this block over here because this doesn't come up very often over here. I'm not going to leave it completely, but I'm going to leave it till last. So we've got parathyroid adenoma over here, parathyroid adenoma, parathyroid hyperplasia, the two things that we've talked about a little bit down here. Just finishing off all of the things for men 1 is all of the P's. So we have parathyroid adenoma, pituitary prolactinoma. So I'm going to do pit prolactinoma. So we've got now P, 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 another P down here. This is pancreatic, causing peptic ulceration. P and P. The reason that you get peptic ulceration in these pancreatic is you get a Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. Zollinger-Ellison syndrome in Part 2 exams specifically. The key in the phraseology to say that the person's got Zollinger-Ellison, so the secret phrase is that they have ulceration past D2 in the duodenum. So anytime that you see ulceration past D2, that is secret language for Zollinger-Ellison syndrome. And so in the same way, blistering over buttocks, blistering buttocks is code for dermatitis herpetiformis, is pathognomic of celiac disease. So all of those bits go in a line. So there's certain phrases that mean specific things. If somebody has a renal function test as part of an insurance medical and it's normal, and then 6 weeks later they've got a creatinine of 500, that is secret language for the person has rapidly progressive glomerulonephritis. So the hormone that's secreted, and that's a gastrin secreting, pancreatic tumor, giving peptic ulceration, Zollinger-Ellison syndrome, and I'm going to write past D2 over here. Now, up here in this box that we talked about, which is this box in B, just being a little aware that this is the last really thing that comes up. Try and remember all of the other things. Up here, I'm going to write it in very small handwriting. And this is marfanoid appearance and mucosal neuromas. So if you are bored and you've learned everything else in the world, then I would, start saying, okay, well, it might be interesting to remember this. The bit that I use to help me remember is that the three M's are on this side, and then I've got the three P's on this side. We're about to wrap up on this topic, but just briefly before we do, pheochromocytomas. We did mention for pheochromocytomas, we had our rule of 10%. I'm holding up 4 fingers. I mean to be holding up 3 fingers. It might be 4, I can't remember. I'll remember when I start writing. So 10% of pheochromocytomas are bilateral. So we find them on both. We find them in both of your adrenal glands. Bilateral. 10% are 10% of them are extra-adrenal. Um, 10% of them are associated with multiple endocrine neoplasia. So if you find, and that's multiple endocrine neoplasia type 2. So bear in mind that you can have pheochromocytoma. Most pheochromocytomas don't happen with multiple endocrine neoplasia. If you do, you should then look for multiple endocrine neoplasia, bearing in mind that if you're looking for multiple endocrine neoplasia, which one is it? It's going to be multiple endocrine neoplasia type 2. So the things that we're doing are, once I've found my pheochromocytoma, I am then doing calcitonin to look for my medullary thyroid cancer. And I'm also doing calcium and phosphate and parathyroid hormones, looking for high calcium, low phosphate, and an inappropriately normal parathyroid hormone level or a raised parathyroid hormone level. So we've got our 10% rule. And then the drugs that we give, the tests that we do, we've already talked about one of them, which is a 24-hour urinary collection of metanephrines. We can do plasma fractional metanephrines. At some point, I suspect this is going to start coming up in exams. You will never be asked to do which one should I do, 24-hour urinary collection or plasma fractional metanephrines. At some point, it may be that the guidelines change to doing this one, but at the moment, we're still on 24-hour urinary collection of metanephrines. Drugs, there are drugs that you need to give, and the order that you need to give them are alpha blocker first, just like the alphabet, alpha blocker first. Phenoxybenzamine, and then beta blockers second. And they won't ask you which specific beta blocker. It has historically been atenolol. The reason being is atenolol is very non-specific, and what you're wanting to do is you're wanting to decrease beta stimulation throughout the body. Now, why don't you give beta blockers first? Because although beta blockers make your blood pressure, although beta stimulation makes your blood pressure go up and your heart rate go up, there is beta 2 stimulation, which makes your airways relax and also dilate some blood vessels that supply muscles and elsewhere. So as you're exercising, if you think about adrenaline, I'm running away, fight or flight. As I'm running away, I need to be able to breathe easier. I need to supply blood to muscles and divert it away from things that I don't need. I need to divert it to muscles. Blood vessels dilate, so I get some dilation and some constriction elsewhere. And if I beta block first, then I lose that dilation of blood vessels around the body associated with beta stimulation, and then I have unopposed then alpha stimulation, and I end up with a hypertensive crisis. You don't really need to remember that mechanism. That's absolutely fine. The bit that you need to remember is first, alpha blocker, second, beta blocker. It's the same type of order that you need to know when we're looking at alcoholics and people with alcoholics who are alcoholics. You might have the trick question in part 2. You've got an alcoholic comes in and they've got a blood glucose of 3.1 and ketones. Which one are you going to give first? Are you going to give glucose first, or are you going to give Pabrinex thiamine first? Which one are you going to give? And your brain incorrectly says low glucose equals a hypoglycemic emergency. I've got to give glucose first, and then you fail that question. Hypoglycemia in somebody not on insulin is not dangerous. Your body, as your sugar drops, people are doing fasting all of the time now. Your sugar levels drop, your body starts to cannibalize fat, you release ketones, your brains can use ketones, your muscles can use ketones, you're golden. If you're an alcoholic, it's not the same as being on insulin, where as an alcoholic, again, you haven't been eating and drinking, you've been feeding your body alcohol as an energy source. That glucose hasn't been around, you use alcohol and then fat and ketones goes up and glucose comes down. So this is not a hypoglycemic emergency where you're going to end up dying the same way as you would do if you had an insulin overdose. So the more important thing is that you give thiamine first so that you don't go get Korsakoffs, and then glucose second. So in an alcoholic, thiamine first, glucose second. In pheochromocytomas, alpha blocker first, beta blocker second. If I've got pituitary failure, the two only hormones from your pituitary that's vital to live, one of them is thyroxine. Well, it's not from your pituitary, but TSH. So thyroxine and cortisol. Which one do you give first? If you give thyroxine first, your metabolic rate goes up, and without cortisol, you have a hypotensive crisis, a cardiovascular collapse because of your cortisol deficiency. So you give cortisol first and then thyroxine. So this is what I'm trying to come across to, is the urgency in certain situations of one drug before the other. And the one drug before the other, we have alpha blockers before beta blockers. We have thiamine before glucose. We have cortisol before thyroxine. I think at that stage I've covered everything that I really wanted to. On that subject, I'm going to move on. Again, just a quick check whether this is all working. Yep, this is all working. I am going to now cover one or two questions that I've been asked to cover. There was quite a few people talked about murmurs, about JVP waveform. People wanting to know about what the dynamic maneuvers were, squatting, leg raise, standing, Valsalva, hand grip, inspiration, expiration, whether that made murmurs louder, whether it made murmurs softer. Which murmurs it exacerbated, also the atrial waveform for JVP. So I'm just going to cover a little bit of that, and then we'll see how far we get. So I prepared a little slide for murmurs, and I'm going to look at it just for a second, and then I'm going to move on from it, because I'm sure everybody's seen this a million times, and it might not have helped them too much. So this is the diagram. The diagram is, I think I stole this from Wikipedia. We can write over the top of it, and it probably does help. We have two types of systolic murmurs, and then we have two types of diastolic murmurs. And then we have things that give you a murmur all the way through in both systole and diastole. So quickly, we're just going to have a look at the two different types of. So see whether my pen writes over the top of this, over these. So this is systole. When the heart is squeezing, the heart pushes on. It pushes the valve, aortic valve, open so that blood can go around the body. But it's important that the back door closes and the mitral valve closes so that blood can move forward. So you've got blood squirting past the aortic valve and also blood pushing against the mitral valve. So in that circumstance, we have two different types of systolic murmurs, and that is A, ejection, and A, sorry, I'm just going to get rid of that part because I've circled a normal person. Okay. Ejection systolic, as the ventricle is squeezing very, very hard, it should be opening the aortic valve, and the aortic valve should open nice and wide. And as it opens nice and wide, it should be fairly silent blood flow across that valve. If that valve is tight, you'll hear the squirting sound in aortic stenosis. If the mitral valve is prolapsing or is regurgitating, then as the ventricle is squeezing, then it's pushing backwards, and you get a pansystolic murmur of mitral regurgitation. And I know you guys know all of this, but it's just to reassure you that there isn't any more magic going on than you think there is. We can do a similar type of pattern, and it's usually a little bit quieter, and I'm going to write this underneath, is pulmonary stenosis. Will give you a similar type of sound in a slightly different area, but that is through the same mechanism of blood is being squeezed past a tight valve. And mitral regurgitation is the same pattern as with tricuspid regurgitation. Again, different area, but the mechanism is the same. During systole, both the mitral valve and the tricuspid valve close, and that squirts back. I'm spending just a few minutes on this because we're going to come back to this because it's important and what is happening with your JVP waveform. At the other side, now the ventricle is squeezed, blood has been emptied out, the aortic valve and the pulmonary valve close. As they are closed, the mitral and tricuspid valve open and blood is supposed to be coming into the ventricle. So during diastole, aortic valve should be closed, pulmonary valve should be closed. So if you hear sounds in diastole, it's either over here, we've got early diastolic and mid diastolic. So we've got ejection and pan when it comes to systolic, and early and mid when it comes to diastolic murmurs. So again, aortic regurgitation gives you an early diastolic murmur. It's over here, you can see it's kind of louder right at the very beginning where the pressure is at its highest in the cardiac cycle. When the pulmonary valve and aortic valve close, the pressure in the aorta and the pulmonary vasculature are at their highest, so they're going to be pushing hardest on the valve. So the diastolic murmur will be at its loudest when that pressure is at its highest, which is the earliest point in diastole. Then mitral stenosis, in mitral stenosis and tricuspid. It's midway through that where the atria squeeze to push blood into the ventricles that the stenotic murmurs will be at its loudest. So it's quite quiet to begin with, and then this happens mid-diastolic, where the valves valves are open and the atria are squeezing against it. Patent ductus arteriosus gives you a murmur that goes all the way through systole and diastole. Now remember, looking at these murmurs above, you can have a combination of both problems with systolic murmurs and diastolic murmurs, and you can have them both at the same time, giving you a murmur throughout. But if they would like a machinery constant murmur going throughout the entire of systole and diastole, that is patent ductus arteriosus. The only other thing that's worth mentioning for exams is an AV fistula. And that gives you a murmur throughout systole and diastole. So that's constant throughout. What I have done for this next section for dynamic maneuvers. This is not something that I teach very often, so I'm sorry if it's not as clear as it could be. We do things, all of our maneuvers are set to either increase preload, increase the amount of blood coming into our heart, or decrease preload. That will make this as easy as possible. So I either do things to increase preload, or I do things to decrease preload. When I increase preload, there is more blood coming into my heart. There is more blood going out of my heart. My heart is working harder. Because my heart is working harder, all murmurs are increased when I increase preload. Right here, harder. All murmurs increase in loudness. I will get more ejection systolic murmur because I have more blood squirting over the valve. My left ventricle and right ventricle are more full, so my regurgitant, both mitral and tricuspid, are louder because I've got more blood being pushed back against that valve. I also have, so that is both, in diastole now, if I pump more blood out my heart, my aortic pressures and my pulmonary pressures will be higher, so my diastolic murmurs of pulmonary and aortic regurgitation will be higher. So all murmurs increase in loudness, except HOCM. Oops, I spelled that incorrectly. Hypertrophic obstructive cardiomyopathy. That actually gets softer. The reason that this gets softer is, somebody's asked whether I can leave this up later. Yep, I'll leave this up later. The reason that HOCM is softer is when you have HOCM, the ventricle, the worst position to get in is when the ventricle collapses fully. And when it collapses fully, the meaty ventricle blocks your outflow tract. And so your ventricle is squeezing a tiny little blood, but not even that blood can come out. So if I increase preload, my ventricle is held open wider, and now it's held open wider, the thick walls of the ventricle don't make as loud a murmur because the walls are open properly. So all murmurs increase with preload, except HOCM, because you're holding that ventricle open. There's one other exception, and you'll see this coming up, these two coming up as a pair over and over again, which is mitral valve prolapse is also softer. Don't bother remembering that it's later, but remember that it's softer. Why is mitral valve prolapse? Well, I said mitral regurgitation is louder. Mitral regurgitation is the valve is stuffed. The valve is broken and it's going to pop backwards, and more blood in the ventricle makes a louder mitral regurgitant murmur. Mitral valve prolapse is a slightly different structural problem where the tips of the valve kind of pop inwards. The more full your ventricle is, the better the valve is held open, and then the quieter the mitral valve prolapse. So these are murmurs because there's something structurally wrong that means that you get a murmur, but all other murmurs, the more blood you put in the ventricle, the more dynamic the ventricle is, the louder the murmur gets. That's not me crossing it out, that's me highlighting it. But it hasn't been highlighted in a very good way. Why don't I undo that? and try and highlight that. Let's see whether that works better. Ah, that works better as a highlighter. So now when I decrease preload, what's going to happen? Well, it's all going to be the other way around. This is now really nice and easy. So when I decrease preload, all murmurs get softer. Because with less preload, my ventricle is less full. With my ventricle less full, with my atria doing less, all of the murmurs are softer, except, and the exception is the other way around. Hokum then gets louder because my ventricle is less full, the ventricle is tight together, the muscle wall is squeezing, and I get more outflow tract obstruction. Mitral valve prolapse gets louder as well, so that increases when I do increases, and also gets earlier. Again, I wouldn't remember this. So now we have more preload, louder murmurs, except those two. Decreased preloader, all softer, except those two. And all you need to do now is remember what maneuvers give you increased preload. What do I do to increase preload? That is, I squat. Actually, I'm going to do it the other way around. Leg raise, because that's what you're actually going to do in bed. I lift the leg up, and as I lift the leg up, blood drains down from my leg and gets dumped into my heart. It's like giving a fluid bolus, lifting your leg up. Now I've lifted my leg up, I've increased preload, I've made all my murmurs louder, except Hokum and mitral valve prolapse. So leg raise or squatting. And when I squat, I squeeze all of the muscles in my legs. That squeezes the blood out of them. That pumps them into my ventricle, and I increase preload. So leg raise and squatting increase preload. What decreases? Well, it's the other way around. I can now stand up. That's when people's preload decreases. Postural hypertension, they haven't got the squeeze, feel all woozy and then pass out. So standing. I can also do a Valsalva maneuver. That also decreases preload. As a pregnant woman lying on my back with my baby squashing my inferior vena cava, that decreases preload. That's why I have to lie in the left lateral position for things, because I don't want to decrease my cardiac output. So standing and Valsalva, that's decreased preload. So now you can see, don't think of these maneuvers as each doing independent things. Leg raise is not different than squatting. That's the same part, doing the same physiological process. So we understand that, I hope. The next dynamic maneuver . We've talked about stuff coming in, which is your preload part. Now you've got stuff going out. And the stuff going out, I can increase my afterload. Well, we did say that the more preload you've got, the more afterload you've got. That's true. So aortic regurgitation got worse when I increase my preload. All of them do, other than Hokum and MVP. But I can specifically just increase my my afterload on its own. I can just do afterload. And if I increase afterload without doing anything to preload, then all of my regurgitant murmurs get worse. Left-sided regurgitant predominantly. So that is aortic regurgitation. AR gets worse because now my afterload is higher, the pressure is higher in the aorta. Because it's higher in the aorta, the valve pops back more. MR, as my left ventricle is squeezing, and I need that back door to hold its own, then as my ventricle is squeezing and I've got high afterload, then the ventricle is squeezing against high pressure and my mitral valve pops back. So this is hand grip. So these get louder. As a side point, what do you think happens to hokum? Hokum gets softer. You don't really need to remember this bit. The bit that you need to remember with dynamic testing is preload, this one here, that do the opposite. I'm just telling you this for information, your own information, is if I've got afterload and I'm doing my hand grip afterload, that helps to splint the ventricle open so that my hokum murmur is softer. But it makes all of my regurgitation, left-sided regurgitation, louder. Last part is, for this dynamic, is inspiration. We had some, remember, dynamic, things that increase preload made murmurs, all murmurs louder. And we had two mechanisms that gave me globally, it increased my preload both left ventricle and right ventricle. Inspiration, so when I inspire, all that does is increase preload for my right heart. So I know that preload increases murmur loudness, and now if I'm only increasing preload with my right heart, all of my right heart murmurs get louder, because this is a specific maneuver to increase preload with my right heart. If I want to increase preload overall, then I do my leg raise or my squat. If I'm only interested in the right heart and I'm listening to the right heart and I don't want to do all of that leg lifting and squatting, I can get them to inspire, and as they inspire, right heart murmurs will get louder. The last one is expiration. Expiration is a kind of cheap one. I don't think it really counts, to be honest with you. All that expiring does is I breathe out, and now my heart is closer to the wall of my chest, so I can hear it louder, especially the left heart, because the right heart is kind of behind your sternum. So when I expire, then I get my heart closer. If I want to get it even closer, then I lean forward as well. Expire and lean. And this just makes my heart closer, which is easier. Doesn't do anything magic, but it's just easier to hear left heart murmurs. So inspire, right heart all get louder. Expire, it's closer to the chest wall, expire and lean. Afterload, regurgitant murmurs of the left heart, because hand grip doesn't do anything with the right heart. Dynamic testing, this is all about preload and afterload. And you've got to remember that hokum and MVP do the opposite that everything else does. So this is going to come up next. So let's see whether we've got anybody left still watching. Oh, yeah, there's some people still watching. So what we are going to do now is I'm going to move on and do some bits about the JVP waveform. Then if anybody is still breathing after that, then I would like to do some stroke bits and bobs. But what I'm going to need to do is quickly pop to the loo. I'm going to leave this running, leave the stream running, but I'll be back very shortly. So I'm going to put the holding card up and I'll be back in as fast as I can run to the loo. Okay, back again. One of the disadvantages of having children late on in life is not only having to face getting old, but having to face being told that you're old by your young children. So my daughter told me today that it's very normal for when you're doing a live stream not to wear your trousers, and I'd like you to know that I'm treating you and myself both with the dignity and respect of wearing trousers as I'm live streaming. So be reassured. Okay, that's the end of our murmurs. I hope that's been helpful, because my general aim is to try and whittle it down to the core components and features, because I find when you look at it in a book, there are long lists of things and you can't work out quite what it is that's happening. You either get a disproportionately long explanation of the physiology of it, or a list without any explanation, and it takes hours and hours to put those two together. So I hope it's been worth your while running through the last two subjects. And we were moving on to, I think, the JVP waveform. How do I get that to move on? Yeah. I'm not going to scare you with that. I'm going to build this up with you so that you understand it. When you are looking at your JVP, as you're looking at your JVP, you're actually looking at the pressure within your right atrium. So your right atrium has no valve on the back of it. So whatever your right atrium is doing, you're seeing it in your internal jugular vein. So the JVP waveform is the pressure that is happening in your atria. Now you get some signals for what the ventricle, the right ventricle is doing. You get nothing about what's happening with the left heart. This is only what 90% of what you see is what the right atrium is doing. And then a little bit of what the right ventricle is influencing the right atrium. So I'm going to draw it from the point of view of the right ventricle to begin with. So let's get my pen out. So let's try and draw this as a mechanism of this over here is the tricuspid valve. And this over here is the pulmonary valve. And this is your pulmonary artery coming off this. Okay, so this is the ventricle. And this is, let's go back, do that in a different color. This is your ventricle and this is your atria. Now this is all right side of your heart. Oh, I've drawn that valve back to front. Okay, my rubber. As you can see, I don't teach this subject very often. So, when the ventricle squeezes, this doorway closes so the blood doesn't go back in this direction and blood comes out here. Then, when the ventricle relaxes, this pressure here is high, this door closes. As this relaxes, you can now have blood coming into the ventricle. That kind of makes sense. So the first waveform that I'd like you to understand is just the fact that the blood is going to fill the atria. Then blood is going to go from the atria into the ventricle. And then eventually that's going to become overfull. And then there's a squeeze and then the whole cycle repeats. You'll understand it once I draw it out a little bit more. So this is I'm going to draw a few cycles of it. And we're going to add in some stuff later, but let's just do it like this. So over here, the atria gives a squeeze, and it squeezes blood from the atria into the ventricle. So that's what happens. So this over here is A. The atria squeezes and squeezes the blood into the ventricle, and the pressure goes up because there's a squeeze. Now the atria relaxes, and this is the atria relaxing over here. Blood is flowing into the atria, into a now relaxed atria, and as it relaxes, its volume increases, and so pressure drops. You can see this pressure dropping because the atria is relaxing. Blood is filling it. Eventually it will get to the point where the atria is full, and then the pressure starts to increase as the atria gets more and more and more full, until eventually, when it's at the fullest it can be, it does a squeeze over here, the peak at the top, and then it relaxes, and the atria now is squeezed and relaxing, so the pressure drops. As the pressure drops, blood starts getting sucked in. Eventually, at this point, the atria is starting to get full, and pressure starts to go up again. Because the atria is full, it gets more and more and more full as we get up there. Then eventually it does another squeeze. And it does another squeeze, then relaxes. As it relaxes, the pressure goes down until more and more blood enters. More and blood enters over here. It's starting to get full, so the pressure starts to increase until it eventually does a squeeze. So you've got the cycle of a squeeze, squeeze, relaxation, but blood trickling in. Blood has trickled in till it gets to the point where the atria is quite full. Then pressure increases because it's getting more and more overfull, and then it squeezes again and then relaxes, and because it's relaxing, pressure drops in the atria, but it's still trickling full, trickling until it gets to the point here where it's quite full, so pressure starts to go up and more venous return is coming back and it's trickling up, and then the atria squeezes again, then relaxes, and you go through that cycle over and over again. So this is, check that this is working, yeah. So this is what's going on in your atria, and we just need to add a little bit of extra information on top of this, and as long as you understand that bit, you are home and dry. So I'm going to draw this again. So I'm going to draw this in white. So we must understand this is what's going on underneath. So this is all at the top here, at each one of these, this is the atria giving the squeeze. The atria have squirted blood into the ventricle during that A section here. So it squirted blood into the ventricle, and then as soon as that squirt is over, then the valve closes. This atrioventricular tricuspid valve closes. So the atria squeezes, then the valve closes because the ventricle is starting to squeeze, and you get a little hump on the over the top of this. So the atria squeeze, you get this bit at the top. The atria are relaxing, but now the ventricle squeezes and this valve bulges back a little bit as this ventricle is squeezing. So you get this little lump at the top here. And that little lump at the top there is called A. I've got a little chart here that I'm hoping that I've got to send across to you. Yeah, I have. Okay. This is called your C wave. So you have your A wave, which is your atria squeezing. It's relaxing, blood is falling. Blood is falling into the atria, but it's relaxing, so pressure is going down. The ventricle squeezes, bulges the valve back, but the atria is still relaxing and still filling. We have now reached the point where no more blood really can fill in the atria without the pressure going up. The pressure starts to go up at this stage. Then we get a drop in pressure over here before it carries on going up again. So I'm now adding in more features so that you can understand. this over here. This drop over here, this is caused by now the valve opening. So this is your tricuspid valve opens. Blood can now fall in, so it gives a little bit of extra space because that valve is opened. Then you end up having a squeeze of your atria again and you get your A wave. So this over here is Y descent. This is due to the valve opening. This bit over here is just before, over here, this is called your V wave, and this was where your valve is still closed. Closed tricuspid valve. So the closed tricuspid valve opens. Let me get my laser pointer. My atria is filling, the pressure is going up. Over here, the valve, tricuspid valve, is still closed. Then it opens with your Y descent. Then the ventricle and the atria are both filling. The atria squeeze. The ventricle starts to squeeze, close the valves, bulges back, and then it carries on descending. So let's come back to now to redrawing this. And I'll talk you through each steps. You covered it so many times in medical school and reading about it. It's quite difficult to describe because you've got filling and pressure are two different things. You can fill and pressure's dropping because muscle's relaxing. So as it's filling and relaxing, pressure is going down, even though the volume of blood is going up. Then you've relaxed as much as you can, more filling carries on occurring, and then the pressure starts to go up. And that's what's happening at the bottom of this JVP waveform. At the bottom of this JVP waveform over here, you're getting to the point where the atria are filling, but over here, we've now reached the capacity of the amount of blood that you can get in it without the pressure going up. And over here, it's still filling, but the pressure is going up because we're now reaching the end of packing as much as you can into your suitcase. So just a quick talk through, and then we'll talk through pathologies of each of those valves. It's a little bit dry, but people have asked me to cover this. So we have A wave, which is your A wave equals your atria, your right atria squeezing. That's your A wave. Then the valve closes as your ventricle starts to squeeze, and the valve bows back into the atria, and over here gives you your C wave. C wave equals, to me, this is closing of valve, and it bowing back. Over here, you then have this whole part down here is called your X descent. But because this part here is quite short, we end up referring to this bit here as the X descent. And X for me is in relaxation of your atria while they're slow filling. So we've got your X descent coming down here. Then we get to the bottom of this. Then this changes direction over here as your atria gets more and more full. Then we get your V wave, which is valve is still closed. Then we have your Y descent, which is valve open. And then it carries on filling until we repeat the cycle over again. So for the 3 people that sent to me that they wanted to cover the JVP waveform, the bits to take away now are JVP waveform is showing you what's happening in the right atrium. That's part number 1. you get little clues of what's happening with the tricuspid valve. What happens when the valve closes and the ventricle squeezes, and what happens when the valve opens and you get this drop in pressure because now you have an open ventricle to pour atrial blood into. And then we're back into the A wave again, where the atria squeezes, and that's this top portion here again. So this is atria filling. This is atria is filling all of the time here, but relaxing. Then it's full and the pressure is going up. The valve opens and you get a drop in pressure, and then it carries on filling again before it squeezes. So these are all just an analysis of what's happening with the right atria, as well as seeing when the valve bows back, which is your C wave, when it bows back, and then when it opens, which is your Y descent, and now you've got extra space. So a bit dry, but requested. So just very quickly about pathologies then that you get in your JVP waveform. So let's start with A. We said that A happens when the atria squeezes. Right atria squeezes. And if that right atria is squeezing through a tight valve, then that's going to be big. So increased A waves. Let's cut this out. Increased A wave equals the atria squeezing through a tight valve, tight tricuspid. If the tricuspid valve is okay, but your left ventricle is really meaty and hypertrophied, then you're going to find that the A wave is bigger because the atria is trying to squeeze into a very small, tight, fat, hypertrophied ventricle. So RV hypertrophy. You can think about all of the different diseases that causes right ventricular hypertrophy. You can have pulmonary stenosis, pulmonary hypertension, cor pulmonale. All of the things that cause it cause right ventricular hypertrophy, but it's the right ventricular hypertrophy that gives you the giant A wave as it's squeezing against it. You can have A waves that are Cannon A waves. So there's increase, giant A waves. You can have Cannon A waves. And Cannon A waves are where the atria squeezes against a closed a tricuspid valve. So the atria squeezes, the valve is supposed to be open and the atria squeezes. But if you have dyssynchrony, so ventricles are squeezing slightly different than atria are squeezing, so they're squeezing at different rates, this is doing their own thing, then at that stage you're going to get Cannon A waves. So those are things like complete heart block. VT, where the ventricle has got its own rhythm going very fast and the atria is just doing the sino-atrial wave, and the ventricle tachycardia is doing this, and then you've got your atria doing this. They're doing it in a dysynchronous way, so you end up with Cannon A waves. The same is true when you have an AV nodal reentrant tachycardia and junctional rhythms. These are the two that tend to come up in part 1 exams. This sometimes comes up in part 2 exams. You won't have A waves. You won't have them if you've got atrial fibrillation, because your atria is doing this, and as it wobbles around, it's not going to produce that peak at the top of a peak proper A wave. We come back to this. We said this was a C wave, and this over here was a V wave. This is a C for closing of your tricuspid valve. This V over here is when the valve then opens, and then you get your Y descent. You can have a very high and large V wave. This is when it opens with tricuspid regurgitation. Okay, I think I'm going to leave A waves, CEV waves, and the jugular waveform at that point. What I was also asked to cover was some stroke stuff. So we'll move on to stroke stuff. Okay. So the bit for strokes people asked for was, how do you define what is an ACA, anterior cerebral artery, MCA, and PCA infarct? How do you tell the difference, both with the symptoms? And then particularly, what about brainstem strokes? And those were broken down into your midbrain, which is the top of your brainstem, then your pons, which is in the middle, and then at the bottom you've got your medulla oblongata. So there are stroke syndromes when you have strokes in each of those areas. Those are things like medial medullary syndrome, lateral medullary syndrome, etc., etc. So we're going to run through those as quickly as we can. I know I'm reaching time-wise probably about what anybody can bear. Okay. So, yep, stream's all working. So we're going to start off with giving some foundations. We talked, when we were doing glomerulonephritis, we talked about some of the major syndromes that you got. So when you had hematuria at the same time as an upper respiratory IgA nephropathy, we had hematuria 10 to 14 days after an upper respiratory post-streptococcal glomerulonephritis. We had a nephrotic syndrome in a child, minimal change disease, or primary focal segmental glomerulonephritis. Then we had a nephrotic syndrome in an adult. It was less clear, but most commonly membranous, thickening of the basement membrane on spikes and silver stain. And then it kind of gave you a framework to start to work out what it was that was going on. And that's where we're going to start at the moment. So the mechanism that I'm going to move through is there a problem with sensation? If there is a sensation problem. The further you've got to the front of your brain, the further down the body your sensation relationship is. So if you have an anterior communicating artery, anterior cerebral artery stroke, then that leg is affected much more greatly than your arm, and not rarely your face. So this is leg predominant at the front of the brain. If your arm is affected, or your face and arm are affected more than your leg, then that's MCA. Face and arm much greater than your leg. If you end up with a pure sensory stroke or a pure motor stroke, so let's say pure sensation only, then that is a lacuna infarct. Lacuna equals pure sensory. If you have a problem with sensation from a level of your body downwards, then that is going to be a spinal cord problem. Equals a level. So pure sensory, I'm going to come back to what I mean by pure sensory. Pure sensory, I mean no cortical signs. So in an ACA infarct, you have both the combination of my leg is affected much more than my arm and not my face, and I have cortical signs. We'll talk about cortical signs. MCA, my face and arm is affected much more than my leg, and I have cortical signs. If I have sensory features only without any cortical signs, that's lacuna, and if I have a level, then that is a spinal cord problem. So, what are cortical features? So sensation and motor are carried up and down in spinal I don't know, so we've had a bit of a problem here. Is this still working? Yeah, that's working, but the camera's died. So give me a second just to get this camera working again. Give me a second. A technical issue here. Sorry about this. I've got to try and fix this. Just bear with me. I'm going to go back to a holding card for a second while I try and fix this if I'm able to. So bear with me. Okay, I'm going to carry on for a little while longer. I haven't managed to sort out the camera issue, but I can still see the open board thing, so I'll pop back between the main view and the open board for as long as that seems practical. Okay, we're going to talk about cortical features, and cortical features are any of the components of your brain that deal with higher function. And what I mean by that is features of dysphasia. In dysphasia, the muscles of speech work fine, but you can't make words and you can't understand words. So that is both receptive and expressive dysphasia. That is features of an MCA infarct, and this is usually frontotemporal region. We have apraxia or dyspraxia. And apraxia is, again, a dominant parietal lobe, and that's features of an MCA infarct. So these are cortical features of an MCA infarct. Neglect. This is non-dominant of an MCA. And then if you have a homonymous hemianopia or cortical blindness, that is a PCA issue, posterior communicating artery issue. That is Okay. Oh, no, now my computer's throwing up errors. So I think that's probably about as much as my computer can bear. I've got a couple of technical issues to line out. I will send out to you. I've done some notes for you about all of the individual cranial nerve pathologies, so about what you get when you have a midbrain problem. That's usually third nerve plus cross signs. When we have PONS, we move on to sixth and seventh nerve, and then we go into medulla when we're up to 9, 10, and 12 cranial nerves with mixed signs as well. So I'm going to send out to you a little pack with stuff about stroke that I compiled that I was roughly going to teach to. I'll also send you out a spreadsheet with about 250 questions on it. They're simple. What causes this, with an answer to it of a high yield of things that you can do in your last couple of days. I'll try and get those out by later on this afternoon. Sorry that we've had a technical issue. I think I'm going to need to do a little bit more work before I can make this happen. It's been lovely teaching you all, and I'm going to wish you all the best of luck for your exam. I hope that everything goes well. I'll leave what's up if it's going to be helpful for the next few days. I might cut out the bits on murmurs and things like that if that's going to go down well. If there's anything particular that you would like to ask as a question, send me an email. I'll see what I can do in the amount of time that is left before your exam. But wish you all the best, and I'll see you guys around, probably clinically sometime.